Director Sadwith, California has a large Medicaid program, spending more than $4.7 billion in 2025 on home and community-based services alone. Fraud in these services, as you would recognize, is a serious matter. In some cases across the country, patients have died when fraudsters bill Medicaid for services that were needed but never provided. Your office has stated in correspondence with this committee and CMS that California goes beyond federal requirements for providing screening and enrollment. If that is the case, why has your Medicaid agency classified all Medicaid-only providers as limited risk, a classification that comes with less stringent oversight standards? Do all of California's Medicaid providers being considered as limited risk really reflect what you're seeing in these programs?
Thank you, Chairman, for the question, and thank you again for the opportunity to be here today. Home and community-based services are a vital program in California. We know, for example, that they're cost-effective, reflecting a prudent use of taxpayer dollars. 1 year of receiving in-home supportive services saves federal and state taxpayer dollars approximately $100,000 compared to a stay in a nursing facility. And we are absolutely committed to ensuring the integrity of these vital services.
But by classifying all Medicaid-only programs as limited risk, are you seeing that all of these programs really show the limited risk as far as fraud goes?
Thank you for the question. So the risk classification, categorical risk level classification, is one of many tools that we use to assess program risk.
Is this adequate? When you paint with one brush all of those as limited risk, which requires less oversight, are you missing fraud?
We employ a number of safeguards to prevent bad actors from entering the program. For in-home supportive services specifically, we do conduct fingerprint and criminal background checks, which is one of the features of a high-risk categorical level designation. So even though—
But that's high risk, but we're talking about limited risk, which you ascribed to all Medicaid-only providers. Does that catch all the fraudsters, or should this be more of an individualized approach and not painting just with one brush? Is there an opportunity to really weed out the fraud at its beginning stages?
I absolutely share your focus.
Have you previously designated any Medicaid-only provider types that were classified as moderate or high risk?
To my knowledge, we have not classified any Medicaid-only provider types. We have gone above and beyond, historically, the federally designated risk
In
levels.
California, are you reassessing any provider risk designations in the state?
Thank you. We are actively assessing opportunities to strengthen program integrity in key areas. This includes, but is not limited to, the categorical risk level designation. We do have other tools that we use to go after higher risk areas. We have developed provider risk profilers for services such as hospice care, such as dental care, and other areas that are on our radar that we use in conjunction with comprehensive—
Okay, Sheila, you brought into this conversation now home health and hospices. Am I correct that California license home health and hospices before they can operate in the state?
Thank you for the question. This is a really important issue that I'm happy to talk about. It's really important.
Please do.
Yeah, the partnership between the state of California and the federal government is paramount to making sure bad actors stay out of the program when it comes to hospice care and home health. Just as context, Medicare, the federal program, is the primary payer for hospice care in California. The State Department, California Department of Public Health, my sister state agency, does perform licensure for hospice providers. And the state has acted swiftly to root out bad actors.
So before they can operate in California, this is just a simple yes, no. Do you allow this hospice organization to operate with or without a California license? Is that required before they can operate in California? Yes or no?
The California Department of Public Health has imposed a licensure moratorium that was enacted in 2021, and just this week implemented new regulations strengthening the standards for licensure for providers to be able to obtain a
So
hospice
prior to
license.
just this week, your words, you could operate a hospice in California without a license. Is that what you just said to me?
Pardon me, I respectfully disagree with the framing. I'm actually not an expert on that specific.
Okay, so let's move on. Director Basiri, personal care and home health aides are the largest and fastest growing job category in New York, and according to CMS, accounted for more than $44 billion in total payments between 2023 and 2025. I understand, based on information that New York provided to the committee just yesterday, even though it was requested in March, that New York State Department of Health is in the process of designating waivered personal care services as a high-risk program. Given that CDPAP, which is a self-directed personal care service waiver program, is provided in private homes with minimal oversight, what safeguards currently exist to verify the services are billed actually and delivered?
Thank you for the question, Chairman.
I'm going to ask you, my time has expired, I'm going to ask you to respond to that in writing.
What you just watched is not an isolated exchange. It is the latest chapter in a months-long fight between Washington and Sacramento over the largest Medicaid program in the country. Here is the background you need. Federal law requires every state to assign Medicaid providers one of three risk categories: limited, moderate, or high. That label determines how closely a provider gets screened and monitored. California has placed every single Medicaid-only provider type in the lowest category. Sadwith's defense was that California does fingerprint checks anyway. But those checks are a feature of the high-risk designation. If you are doing high-risk screening without the high-risk label, your classification system does not reflect reality. And federal regulators have already noticed. Just last month, Vice President Vance announced from the White House that CMS was withholding over $1 billion in Medicaid funding from California, saying the state had not taken fraud very seriously. The bulk of that money was tied directly to home care spending, the exact services at the center of this hearing. CMS Administrator Mehmet Oz called it the largest Medicaid deferral in the agency's history. Then there is the hospice moment. California hospices had been operating under a 1990 licensing law with no modern, comprehensive regulatory framework, what one legal analysis described as a regulatory vacuum. The first comprehensive hospice regulations were only filed on June 11th and took effect June 22nd, 3 days before this hearing. That is the just this week Sadwith was referring to, and that is why Joyce's follow-up landed so hard. The detailed rules governing how a hospice staffs, trains, and documents care did not exist until days ago. California is not doing nothing. It has revoked licenses, it has task forces, it has background checks. But when a program grows home care spending at twice the national average, classifies every provider as limited risk, and just adopted modern hospice standards days before a congressional hearing, the question writes itself: was anyone minding the store?